Good day, everyone. We are the Group 4, and today we will present a case study about Enterobacter cloacae pericardial effusion in a frail elderly patient. And I would like to introduce my group mates who are Eve Lea Dait, Christine Talatala, and Siti Dambong. So to start the case study, we will start with the background.
Bacterial cloacae is an opportunistic facultatively anaerobic gram-negative bacterium of increasing clinical significance accounting for up to 5% of hospital-acquired sepsis. So Enterobacter cloacae is a widely distributed in the environment. It exists on human skin and gastrointestinal flora, and also in water, soil, sewage, meat, and hospital environments. Although outbreaks have been associated with a single exogenous source, for example, contaminated intravenous fluids, stethoscopes, and intra-arterial monitoring devices, studies suggest that most infections arise from hospitalized patients' endogenous gastrointestinal flora. The next slide, please. Its genus Enterobacter species is recognized by Public Health England and Centers for Disease Control and Prevention as an emerging global health concern with evolving resistance to carbapenems over the last decade. Cloacae's ability to adhere to and invade eukaryotic cells and to chelate iron in the host bloodstream is key to its ability to manifest wide variety of extraintestinal clinical manifestations. E. have been identified as a causative organism in lower respiratory tract infections, urinary tract infections, intra-abdominal infections, endocarditis, septic arthritis, and soft tissues infections. Next slide, please. Chief complaints. We report a case of frail 82-year-old man with seronegative rheumatoid arthritis and a recent pacemaker insertion admitted with pulmonary edema and symptomatic pericardial effusion. An 82-year-old Caucasian man presented with a one-week history of increasing dyspnea and bipedal edema on a background of several months of general malaise. He had a past medical history of seronegative rheumatoid arthritis, severe aortic stenosis, and sinus nodal disease, for which a permanent pacemaker was inserted 4 months previously. He had a low anterior resection for Dukes B adenocarcinoma over 30 years ago. He also had a history of recurrent urinary tract infection for which he has a prophylactic antibiotics for over 20 years. On clinical examination, he was hemodynamically stable and apyrexic. He had marked pallor but was comfortable at rest with no signs of respiratory distress. He had no stigmata of infective endocarditis. On palpitation, he had slow rising regular pulse and his jugular venous pressure was raised at 6 cm. On auscultation, he had an injection, systolic murmur, and bilateral basal crepitation in his lung fields. His abdomen was soft and non-tender, with no masses or organomegaly and normal bowel sounds. He had bilateral pitting pedal edema. A digital rectal examination revealed a 3 cm ulcer at the anterior anal verge with dark and empathic faces. Next, Yax.
So for the laboratory findings, he was treated with diuretics. Diuretics are substances which promotes diuresis, with which increases production of urine. And he was also treated for an urgent pericardiocentesis or a procedure done to remove fluid that has built up in the sac around the heart or pericardium. A sample from which cultured Enterobacter cloacae is also seen in his laboratory findings. Also, a subsequent abdominal CT scan revealed fecal loading, an abnormal anorectal canal and sigmoid colon, and a bowel perforation. Bowel perforation is a hole or tear in the bowel. With this happening, bowel contents can leak into your abdomen through the hole and may cause life-threatening infection. Next, please. For the diagnosis, endoscopy, biopsies, and histopathology confirmed a diagnosis of cytomegalovirus CMV colitis, or CMV colitis occurs in patients with acute severe ulcerative colitis, particularly patients treated with high dose of steroids, and CMV colitis is almost always caused by reactivation of latent CMV infection in immunocompromised patients. Basically, this patient is already immunocompromised due to his pacemaker. And they postulated that the bowel perforation resulted from a combination of CMV colitis, fecal loading, and steroid therapy, and led to bacterial translocation of E. cloacae and the development of the pericardial effusion. This case represents an unusual pathophysiology for the development of an E. cloacae pericardial effusion. Pericardial effusion means excess fluid between the heart and the sac surrounding it. Next, please. So, since I'm not a doctor, I can't give you a explanation about the CT pulmonary angiogram, but it shows that the CT pulmonary angiogram demonstrating a 3 centimeter pericardial effusion, bilateral pleural effusions, and artifact from a ventricular dual chamber pacemaker lead. So basically, ang kailangan lang natin parang i-recognize dito is there is an excess fluid between the heart, kaya hindi normal yung nafe-feel ng patient. So next please. So, as you can see, this is a flexible sigmoidoscopy or a procedure to look at the colon of a patient, and the flexible sigmoidoscopy of the upper rectum, which is edematous with linear ulcerations, and also sigmoid colitis, both of which were biopsied. So, ulceration is the formation of a break on the skin or on the formation of an organ. So, if you can see, parang nag-leak na ito siya or merong ulceration na nakikita sa kanyang upper rectum. So, yun next.
So for the biopsy, histology from both areas, however, revealed active chronic ulceration with deep-seated granulomatous inflammation and fungi, together with features suggesting an ongoing cytomegalovirus colitis. So colitis, it refers to the chronic digestive disease of the lining of the bowel. Now, in this picture, a biopsy taken from the ulcer at the anterior anal verge demonstrating a cytomegalovirus inclusion beside a vessel with background inflammatory changes, H&E staining times 40 microscopy. So the arrow pointing here demonstrate a cytomegalovirus inclusion beside a vessel. So for the biochemistry, microbiology, and cytology results from aspirated pericardial fluid, the results for biochemistry is protein, which is 39 grams per liter. So the normal range for protein in grams per deciliter is 6 to 8. So the equivalent of 39 grams per liter is 3.9 grams per deciliter. So it means the patient has a low level of protein. And this also indicates an inflammatory bowel disease. So for the next, which is cytology, this sample consists of a few lymphocytes and macrophages in a background of red blood cells. and no malignant cells identified. So that's the important thing. Now, in the microbiology section, epithelial cells were negative. Gram film was gram-negative bacillicin, which is the Enterobacter cloacae. Next is that the macroscopic appearance of the pericardial fluid sample was blood-stained. The pus cells was +1, and the red cells was +2. And there is also a heavy growth of Enterobacter cloacae in an enriched aerobic culture. And in an enriched anaerobic culture, there was no growth after 2 days of incubation. So in line with this, blood cultures were taken prior to the pericardiocentesis and showed no growth after 5 days of incubation. They were, however, taken at a time when our patient was already receiving antibiotics for suspected community-acquired pneumonia. Blood, blood cultures were unfortunately not taken prior to the initiation of antibiotic therapy, and no further blood cultures were taken during our patient's admission. So in here, um, blood cultures must be taken before any antibiotic therapy because it will interrupt, or it will make the results into a negative result when the patient has taken any antibiotics before a blood culture. The reason why this happens is because the antibiotic will inhibit the growth of the bacteria. That's why the results are negative for this. The blood cultures are negative. So that's it for the biochemistry, microbiology, and cytology results from aspirated pericardial fluid. For the continuation of diagnosis, serum CMV IgG was greater than 180 IU per ml, which is there is an antibody detected, and IgM, which is 137 AU per ml, 0 to 18 AU per ml, consistent with CMV infection. So CMV serology from the different hospital admission 8 months previously revealed CMV IgG of 70 IU per ml and CMV IgM 18.8 18 AU per ml, suggesting that the current infection was a reactivation of latent CMV infection. So furthermore, CMV PCR was conducted twice on blood and was negative. However, an immunohistochemical stain for CMV on the biopsy samples was positive. So to their knowledge of the researchers, CMV PCR was not conducted on the biopsy samples, and consent for HIV testing was obtained and was negative. Now, collections of fungi were seen microscopically in the deep aspect of the biopsy. Some are also present within the lymphovascular spaces. A periodic acid shift stain confirmed fungal elements, and the infectious disease service recommended the treatment with fluconazole. So they postulated that the frail elderly patient has suffered a bowel perforation from combination of CMV colitis and fecal loading that allowed Enterobacter cloacae to enter the bloodstream and spread hematogenously to the pericardium, where it led to the patient's presentation with the pericardial effusion and cardiac compromise.
So next is the differential diagnosis. So the patient presented with atypical pulmonary edema in the setting of hemodynamically significant pericardial effusion and a recent development of iron deficiency. So the initial differential diagnosis included decompensated aortic valve disease, ischemic left ventricular failure, and superimposed community-acquired pneumonia. So the pericardial aspiration led to the primary diagnosis of an Enterobacter pericardial effusion. Next. So the nature of the organism and the iron deficiency anemia led to a focus on the gastrointestinal tract and colon that subsequently demonstrated the bowel perforation and fecal loading. So when the fecal loading was treated and the sigmoidoscopy were performed, the initial differential diagnosis was a recurrence or a new primary colorectal tumor. So the subsequent biopsies provided the unexpected finding of CMV colitis. The patient had long-standing leukopenia and had frequent urinary tract infections throughout his life, but had no specifically defined immunodeficiency state. He also had inflammatory arthritis, but was seronegative for rheumatoid arthritis. And also, he had splenomegaly, but the opinion from the hematology and infectious disease services was that he was most likely immunocompromised as a consequence of being frail and elderly rather than due to a primary immunodeficiency disorder. So the patient declined bone marrow examination. The recent pacemaker insertion was considered as another potential source of invasive Enterobacter infection, but in this case, it was felt to be more likely that the source of his infection was his own gastrointestinal tract. So after for the differential diagnosis, let's proceed to the treatment. On, on the advice of the researchers infectious diseases service, the 82-year-old man was treated initially with gentamicin. The Enterobacter cloacae infection was successfully treated with 6 weeks of intravenous meropenem, while the CMV and fungal infections were treated with a combination of valganciclovir and fluconazole. The surgical team deemed that he was too frail to tolerate any major surgical intervention. A minimally invasive defunctioning colostomy was offered, but the patient tended to refuse it.
So that's it, and thank you, groupmates, for the information. I would also like to add up that the bowel perforation was caused by the pericardiocentesis, or the drainage of the pericardial fluid. So we have also researched about that, and it is also a fact. So that's all, and thank you.